because there are so many elements in this. But if I have to connect the previous talk, like noise and rounding, one aspect to limit alarms is stop monitoring. So something I do in all my rounds on a daily basis, does this patient need monitoring? That's especially challenging in the US because they are hardly, let's say, willing to stop monitoring. And I have two examples how it can work. So we had a patient that had a high level of maintenance of a severe wound, and the general ward said, no, we cannot do that. That's way too complicated. So we kept the patient in the ICU, and I said, so why does he need monitoring? If he would be on the ward, he would have no monitoring at all. So let's stop monitoring. And we got into an ethical discussion whether you cannot monitor in the ICU, whether it's a legal requirement to monitor a patient once they enter the ICU. And finally, after 2 days of discussion, the nurses said, okay, we're going to stop monitoring. And so I walked to my room to get something. I came back, and the patient was sitting next to his bed in a chair, and he was sweaty, and his eyes were wide open. And I said, what's wrong? And he said, I'm dying. I said, dying? From what? They said, and he said, well, a nurse came. She took off all the electrodes and turned off the monitor. So this is it. I will probably die. The other element was a few weeks ago in Bellevue, where we had a patient where the general ward said, we cannot take care of this patient. He had ALS, and he managed his home ventilation at night, and then he was put on an invasive ventilation, and during the day he managed without ventilation. And I asked the same question. I said, why does this patient need monitoring? Because on the general ward, he won't be monitored. And so after days of discussion, they said, okay, let's stop monitoring. So we stopped monitoring the patient. And the same day, he said, so I'm not that sick. And we said, no, you're not that sick. And then he said, so I don't need ventilation at night. And he stopped ventilating himself at night because he said, if I'm not that sick, if I'm not requiring monitoring, why would I require mechanical ventilation? So it can work in many ways, but a very powerful tool to reduce alarms is stop monitoring, everyone. Okay, let's go to the real stuff. Disclosure, the symposium is a Philips symposium, and I'm in the advisory board of Philips, and I will come back at the end to another conflict of interest that will explain itself. Now, the first goal, the first element, is what is the ultimate goal for a patient that comes into your ICU? It's a very simple goal, is get me the hell out of here. That's your objective when you admit a patient to the ICU. You want to get the patient out because you never admit patient to be in the ICU for the rest of their life. And so transitioning of care, get the patient out of your ICU environment into, let's say, a somewhere else environment in your ICU, in your hospital, or maybe even outside your hospital, very prominent in the US to place patients in long-term care facilities. But basically, if you go to the root, the objective is to discharge the admitted patient. Now, there are many elements of how to get the patient out. It's, of course, the severity of disease. The more severe, the longer it takes. And, of course, the quality of care, the quality of your doctors, nurses, and attendings. And two elements are not much in control for us, like the comorbidities of the patient or the quality of the rehabilitation at the end will ultimately play a role in how the patient will come out of his disease or intervention or surgery. There is something about these comorbidities because in many cases we would be happy to have good details about comorbidities, and especially in the context in Bellevue Hospital in New York where I work. I mean, we sometimes don't even know the name of the patient. We have no clue what's going on with the patient, and even no clue about comorbidities. And in many cases, patients come like, yeah, well, I had this heart surgery, I think 3 years ago, maybe 4, and then the father says, no, 6. And so you're completely lost in all those comorbidities, where basically with all the internet and let's say connectivity between between hospitals and even between countries, it shouldn't be that difficult if you, let's say, deal with the patient sensitive information to exchange all of this. There should not be a huge problem in, let's say, recording what you have done with the patient and make it accessible to everyone else who's subsequently dealing with the patient. But as you can see from this slide, even though a lot of ICUs and hospitals have these electronic systems, the exchange between and the differences between countries is still very limited. Another aspect, and that's basically the part where we come in as intensive care, that's of course the diagnosis, the treatment, and the ultimate discharge process, and a very important element is prevention of complications. And I think that's an important element when you round, because there you can identify possible complications or complications that are very likely to occur, and in many cases prevent errors. And we know that all of this plays an enormous, has an enormous effect on your ICU stay. And if the ultimate goal is to get your patient out, you want to prevent all of this, to keep the patient as short as possible in your ICU. And we know that errors, and especially medication errors, play an important role. And if you can reduce medication errors, this has definitely impact on the quality of care. In a recent PhD thesis from the Department of Intensive Care in Erasmus, Lisbeth Bosma did studies on what's the effect of using pharmacy services during rounding. And she did it in the internal medicine ward setting, but also in the ICU setting. And what she showed in her research is that clinical pharmacy services, even when provided by a junior hospital pharmacist, has a significant effect on quality of care. And in the ICU, where she did the study, it resulted in clinically relevant interventions, and even appear to be cost-effective. So I would urge you to use the guy like Andrew Strasnitskas, the clinical pharmacist who is rounding every day in Bellevue Hospital, to make you aware of possible problems, of possible medication errors, of optimal dosing, which has a huge effect on preventing errors. And if you don't have pharmacy service during your rounding, I would strongly suggest you to make that happen. It's not only a lot of fun, but you learn a lot from these guys as well. Now, okay, you want to get your patient out. That's not a simple process. That's not like, let's sit in our ICU and let's see when the patient meets discharge criteria and then open the door and get the patient out. It's a very complicated process. And so I won't deal with the in-stream of patients, but also the outstream of patients out of your ICUs. That's not an easy process. And there are a lot of factors associated with that, like the pressure on your ICU beds, surgery. And one thing that we did in Erasmus and also in Isla clinics in Zwolle, where I worked, is to, let's say, adjust the level of monitoring that the patient needs to the pressure of the surgery. And so, for instance, we did a small study in Isla clinics in Zwolle where we showed that within 4 hours after admission of cardiac surgery without complications, the patient doesn't need monitoring anymore. They need a low-level monitoring on an intermediate care. And so what we basically could do by studying this is, okay, if there is no need for very intense monitoring, then get your patient out to an intermediate care and admit the new patient. And that's what we did in Erasmus when we took over the cardiac surgery ICU. They had 12 beds for their ICU, for their surgery program. And we decreased the number of beds from 12 to 6 or 7 and increased the production by 25% just by dealing with this. The patient doesn't need monitoring anymore, so the patient doesn't need to be in the ICU, so we have to create something elsewhere where the patient can be. And so the morning schedule went to the intermediate care in the afternoon, and in the bed of the morning patient, we admitted the afternoon patient. And that's dealing with the pressure and dealing with the monitoring and the discharge. And that, of course, needs significant rounding. And so rounding starts and still starts every morning together with the nurses at the whiteboard where we have all the patients and decide who can leave and who can't leave. And so that's a very important part of rounds. And of course, if you don't create these intermediate beds, you're in trouble. If you cannot submit the patient to the intermediate care or the general ward, you're of course in trouble. Then there is other problems. The patient doesn't want to leave, or the family doesn't want the patient to leave because they don't trust the general ward. Another thing, and that's I think increasingly, at least in my practice in New York, increasingly prominent, is the ward is not comfortable with your ICU patient. The patient was very sick, and especially if you have had patients a week on ECMO, they are like, so basically for a week he was almost dead, he needed a machine to keep him alive, and now we have to deal with the patient. That's very scary. And frequently I get reflections from the ward like, I don't trust this patient. I'm afraid the patient will deteriorate. And so let's say, the level of certainty that the general ward wants does not always, let's say, compare to the level of uncertainty that we as ICU doctors accept. Basically, intensive care is dealing with uncertainty. There's a lot we don't know. And so we are very comfortable in many aspects of the ICU care, so in the beginning, but certainly at the end as well, with uncertainty, where the general ward has a problem. There are ways to deal with this. This is, let's say, a technical solution. Philips is also working on this. You put a patch on the patient, and the patch transmits the SpO2 signal, the respiration, the heart rate, and stuff like that. And whenever something goes wrong, there is an alarm, and someone goes and sees the patient. Sometimes it's even more simple. I discharged a patient 2 weeks ago to the floor with a capillary leak syndrome, a very young patient. And it was a weird diagnosis. They had never seen capillary leak syndrome. She was on some oxygen. And we felt that the level of uncertainty was not matched by the ward. And so I went to the ward and I looked at the patient. I said, well, she's good. There's nothing wrong with her. She's perfectly stable. Yeah, but we're afraid something goes wrong. And I said, so, okay, when you think something is wrong, call me. I gave my phone number. And I said, whenever you think something is not okay, then call me. I will be there in 5 minutes. And for the next week, they never called. And so dealing with uncertainty is important. And if you incorporate it in rounds, we sometimes round on the wards as well, on post-ICU patients, that can have a significant impact. And the other thing is, and that's the last part of my presentation I will focus on, is manage expectations. Now, you can manage expectations of patients. For instance, this patient. This is my 85-year-old mother. And a few years ago, she had a very significant cardiac surgery intervention after a large myocardial infarction. And she said, well, she was afraid of the surgery and of the long trajectory to recover. And I said, well, mother, but that's not how it's going to be. You will have your surgery in the afternoon, and you will come to the ICU in the afternoon. You will wake up early in the evening. You will have your first drinks in the evening. The next morning, you will have breakfast, and then you will be out of the ICU, and on Friday, you will be home. And she was like, that's impossible. That's way too fast for a significant intervention like this. And I said, no, this is what you can expect and what you should expect. So tomorrow morning, you should be sitting next to your bed having breakfast. That's what you should do. And later on, when I went over what happened to her, and she said it really helped that I knew that I would be out of bed, because if they would let it to me, I would not be out of bed. I would be sick and recovering from cardiac surgery. That very simple element is, I think, also a part of intensivists. We need to be prepared for discharge as well. There are frequently you round on a patient and you ask, why is the patient on the ventilator? And they're like, what? I said, yeah, I mean, why is he on the ventilator? Well, we think it's, yeah, he cannot be extubated. Yeah, why not? Well, he was very sick a week ago, and well, let's get the tube out. And so there's not this, let's say, daily assessment of the situation of the patient, or maybe even more appropriate, you do it in the morning, you do it in the afternoon, and you do it before as a faculty, before you go home. And so every time I ask the same question during round, why is the patient on a ventilator? Why is the patient not discharged? And so managing expectations of intensivists is, I think, very prominent. Now, how to do that? Well, what the group from Badawi has done, using the Philips database, an electronic database available to everyone, something like the MIMIC-3. And so the database he used has almost 500,000 patients, and more than 1 million patients, and he used about 500,000 to create a discharge score, and then he tested the discharge in about 250,000 patients in the validation. So the objective of the study was to develop a robust predictive model to predict whether the patient would be readmitted within 48 hours of discharge. And that's what we usually do. If a patient comes back to the ICU within 48 hours, basically we recognize we made a mistake and that the patient should have been discharged later on. And so that's what they set out to do in this study, in a huge number of patients. And these are all the elements of the score that they used. And it becomes immediately, I think, clear to everyone that this is not something that you do during rounding and looking at the monitor and looking at the patient and listening to the lab results and then thinking, well, this is probably okay. With complicated systems like this, we need information technology. This is something our brain cannot handle, and I think you should not even pretend that our brain can handle something complex like this. This is something that you need to be fed with when you round. And so what they found in this study, published already some years ago, 7 years ago, is the area under the curve for the prediction of readmission was not that great. An area under the curve of 0.7 is not incredibly good. But if you look at the actual readmissions within 48 hours and the readmissions predicted by the model, that's interesting, because then you come to the clinical application of using a score like this. And so in the fit of these two curves, you can see that, yes, indeed, this simple score from an electronic management perspective, not the doctor perspective, it is very simple to produce score on an hourly basis in your patient could tell you way before, like, this patient is getting ready to be discharged. And the model is very accurate because the chance that the patient will return within 48 hours is significantly reduced. And when he applied this to the extreme, so what is the ultimate gain of using a score like this? For instance, in the patients that are too well to be in the ICU, so in the extremes, they have a less than 1% predicted probability of readmission. That's definitely a ward patient. And about 20% of the patients in the ICU were at low risk already 24 hours before actual discharge. So that's one day that you gain in 20% of your patients. That's a lot of cardiac surgery if you plan it well. At the other end, if you say, well, more than 5% predicted probability of death, that's a serious mistake that you made. If a patient suddenly dies within 48 hours after you discharge, and you don't discharge the patient with do not resuscitate, do not intubate, do not readmit, and so it's completely not predicted. That's 22% of the patients that died within 48 hours could have been predicted with the discharge score. So in conclusion, that score seems, let's say, very, could be very productive in clinical practice. Just recently, they published in Critical Care Medicine the use of a continuous score and then followed this score over days and hours in patients. And again, a lot of patients, more than 500,000 patients, they use the discharge readiness score. And this is interesting. On the left side, you see patients that survive. And on the right side, the very sick patients that do not survive. And they looked at up to 168 hours after admission. And this is what you expect. You expect a survivor, and especially, I don't know if I can have, yeah, and especially this group. I mean, the group that stays for less than a day, and this is, of course, retrospective, you want to see this score go down rapidly, just like in these patients. And all the survivors have the similar trajectory, a very rapid decrease in their improvement in their readiness to discharge. And once you have these elements, you can start to wonder, why is this patient still in the ICU where the score is completely stable for many, many hours, or in this case days, just like this patient? Why can't we find another solution for patients like this? And what you expect in patients that are severely ill, it either worsens or doesn't change at all. That's what you expect in the early hours. But I think the interest is especially in this group of patients where the score rapidly levels off to a level where the patient could be discharged. And that could help to optimize outflow of patients of your ICU. And that's how Philips has invested in Micah Hiller. Micah is an employee of Philips, and they pay half of her salary to do a PhD in Erasmus with me to use this DRS, this discharge readiness score, in the European and also American context, as you got from the other slides. The validation score, or the DRS score, was validated in an American cohort. So Micah is going to validate this in European ICUs as well, and see whether it performs as good as in this electronic retrospective database. And Hendrik Brach will be a co-promoter on this study. We recruit European centers, and ultimately what we want is to use this in a prospective study and urge doctors to discharge a patient when they meet the discharge score. So, when you think about rounding in the ICU and get your patient out, it's a very complex system. The rounding is very located into this only element of your ICU. And I think this discharge readiness score can, maybe in the future, definitely help you. That's not an easy task, because even if you know what you're looking for, doesn't mean that you're able to lay your hands on. And so we have to invest a lot of work to make this available for you in the future. Thank you very much.